Wednesday Hard Talk starts now with host Farid Ali, and he has two special guests and a special topic to deal with today, to discuss today. So let me say hi and good afternoon to Farid. Allow me to have you invite your guests.
Good afternoon, David. It's wonderful to hear your voice, and good afternoon to the general public and all who are tuning in there live with us. Uh, I want to say a special thank you to Dr. Ronnie Bhola and to Miss Leanne Lazarus for making themselves available to us this afternoon. It's such a privilege to have distinguished persons like yourself join us. It's important that the public get the correct information from the people with all the knowledge. So that excludes people like myself. Dr. Bhola, thank you so much for being here this afternoon. I know you have a busy schedule. There's a notion amongst the public, or generally, an attitude that doctors are the persons to avoid unless the situation is dire. And even then, we delay until the very last minute. So hopefully, programs like this would enhance public perception of doctors, and it would also provide a platform in which to educate the public and to make the public more aware of themselves and need to be more aware of their personal selves in terms of their conditions, so they can engage in what we may call pre-screening, try to detect problems before it becomes dire. So those who are listening to us this afternoon, we have Dr. Ronnie Bhola. He holds an MBBS degree from UE, Jamaica. He's also a fellow of the Royal College of Surgeons, Edinburgh, and holds a certificate of completion of higher specialist training from the Royal College of Ophthalmologists, London. And his qualifications go on and on. Dr. Bhola, you are the living embodiment of experience, knowledge, and wisdom in this area. Um, Ms. Lazarus, when I look at your bio, you're a certified diabetic retinal screener with 10 years experience in the field, and you have a master's degree in business administration with a focus on hospital and health services management. So I really want to thank you all in advance. But let's get it right into it. Dr. Bhola, when I read my little background reading, I'm a lay person here. Um, the Pan American Health Organization, they they are on record of saying that 80% of blindness is avoidable and can either be treated or prevented. They went so far to say that the three preventable causes of blindness are cataracts, glaucoma, and diabetic retinopathy, if I pronounce that correctly. Perhaps you can share with us your view on that statistic and how it impacts upon Trinidad and Tobago per se.
Thanks a lot for having me on the program, Farid. You know, sometimes when I look back at the years, you think, well, being a doctor and doing surgery is what we trained and learned, but preventative medicine is really the key to have an impact and to be able to really affect a country and a population. So I think that World Health Organization's statement about 80% of the blindness could be either preventable, or if if somebody has it, we could reverse it. And that's such a powerful statement to make. In Trinidad, we really want to make sure that we target this 80%, and we make sure that we only really have to see 20% in the clinic and deal with that. But those issues that we really would struggle with and try and manage those. So our goal really is to ensure that we have things in place to prevent disease when we can, and if it is present and reversible, we have a mechanism to reverse the disease promptly, because you don't want somebody who has reduced vision or a blinding condition that is reversible, having a poor quality of life, affecting relatives, demanding a lot of support from society, from their family and friends, when they could contribute to those people and the society in a positive way if we did a treatment or something like that to reverse the blindness. So you want to address your reversible blindness within the population within Trinidad and Tobago, and you also want to be doing screening to prevent disease, especially as we're going to talk today about diabetic retinopathy. We've been looking at the preventable part of that 80%.
In terms of screening, how early or how young should let me put it a different way. Is this limited to a certain age group, or the screening process should begin at a very young age? And what age would you suggest?
Well, I'll bring Leanne to discuss the age and the screening, because as you said, she had about 10 years experience, and I would let her take on that question. Very good question.
Hi, Farid. So international standards is usually from about 12 years old and up, especially if you're diabetic. And the recommendation is you have a screening assessment done once every year, once you are pre-diabetic or diabetic. Um, Normal eye health, you need to check your eyes maybe once every year or every 2 years is a recommendation that you go to your optometrist, you do your regular checks with your ophthalmologist. But those are the guidelines that we follow.
If it is you're doing the screening each year, meaning that you're saying once you're pre-diabetic or diabetic, you ought to screen each year. I would imagine that you're screening to see whether anything developed in the course of a particular year, a given calendar year.
Yes. So we have fundus photography. It is a gold standard for diabetic eye screening in the UK. So what it allows us to do, once you come in, we have a base assessment. So they are categorized into either no disease detected, or if you have background, those are seen within a year. So background would be very minor changes that does not impact your vision. So once we note that, we have a noted recommendation either in 6 months or a year, we bring you back. We have a system that alerts us and lets us know this person needs to come back and be seen. Even if you have nothing going on, our recommendation is annual checks, because the whole purpose is, of course, early identification, early treatment to prevent sight loss.
All right. In my little readings, I read in an article that diabetic retinopathy may not show noticeable symptoms. And I'm quoting here, as the disease worsens, people may experience symptoms such as blurry vision, increased number of floaters, vision that changes between blurry and clear, poor night vision, seeing dark or blank areas in their field of vision, colors appearing faded, and vision loss. When I hear that, I get very nervous, because quite clearly, sometimes I was taking a walk the other day, and I want to know what an ant is doing walking across the lens of my glasses. When I looked, there was no ant. So it seemed to be some sort of floater. So the first thing I'm thinking is, I wonder if I'm diabetic. I'm paranoid, Sometimes when you read and you get information, that throws you off entirely. Everything, you feel something crawl on you, wonder if there's something wrong with your nerves. I don't like information. Sometimes if I stay in the dark long enough, I'm less alarmed because I'm an alarmist. So, having said that, could you walk us through some of these symptoms in terms of whether, if I'm experiencing one of them, let us say the floaters, does that mean I have a diabetic retinopathy problem? Or do you need to have a cocktail of these symptoms? Or the mere fact that you're seeing floaters means you're in trouble already?
Okay.
Talk to some of the symptoms, yeah.
Yeah. The thing is, I think if you're non-diabetic and you get a floater, do not panic.
Mm-hmm.
If you going along normally, like how you describe your experience with the floater, I still need to see you, or you call the clinic and one of our doctors will see you, and we'll see you pretty quickly, because a floater means something has changed from the norm in the eye, and it usually is 99% of the times an agent change within the vitreous cavity, and they clump together, the vitreous, as the vitreous ages, and then they sometimes come a little forward um, at around the age of 50, 60. That usually, that process starts to happen, and that gives rise to those little fly, it's like a little cobweb that you might see coming in the vision, and then you start to think, well, it's somewhere in front of you, and you're kind of trying to move it like that. But the truth is, it's in the eye, it's in the vitreous, it's just an agent change within the vitreous. The reason why we make you come in, within a week or so to check the eye is because sometimes, very rarely, when the vitreous ages and changes like that, the retina could develop a tear or a detachment, something a little serious in the back there. So we just have to check it for you just to make sure that you're okay and you don't have anything major going on in your retina. But the floaters is a very common thing to develop as the eyes age, and it's nothing to be alarmed about. Just call the Trinidad Eye Hospital, and we will check it and reassure you that your retina is fine, absolutely fine. So that is what most likely is going on in the scenario that you discussed there. This definitely doesn't sound at all like diabetic retinopathy symptoms that you experience at all. So I wouldn't go down that road and worry about taking blood tests and doing stuff for diabetes, because diabetic retinopathy, when it produces a vitreous hemorrhage or blood in the eye, which gives floaters. That's how diabetics get floaters. They get a bleed into the vitreous. That happens very late on in the disease process.
Okay.
So you definitely don't have bleeding in your eyes there from what it sounds like. Sounds like just a general aging of the vitreous.
Well, that sounds good. I could live with getting old. When you keep using the word vitreous, what exactly is the vitreous? Because the laypersons listening to you out there, they would be hearing the word vitreous and be lost.
Right.
Could you walk us through what exactly is the vitreous?
Right. So I know we have some people on YouTube and then Facebook. So this is a little schematic of the eye. And this part here is a clear window. I'll describe it for those who don't have video. But the clear window in front is called the cornea. And this cornea in your eye allows light to come in through it. And then it goes through the pupil, the little hole there, this colored bit. And then the light passes through this cavity here, which is called the vitreous cavity. And here is where the vitreous would lie in the eye, this space here. And it's a jelly-like substance which is in this part of the eye, and it's called the vitreous humor. So here is where you would have the vitreous humor, and you can see these little blood vessels here. This is the retina. The retina is like the film in the eye. It's a lining, and it lines the inner wall of the eye. So any changes within the vitreous casts a little shadow on the retina, and that is what produces to you the experience that there's a floater, there's something moving in the vision. So that is what's happening there, and that's the space for it.
But that space is a liquid space. It's not just an empty space. Is it a fluid?
Right. So vitreous is a jelly-like substance. It has water content. 80% or more of it is water, and then you would have other things that makes it jelly-like.
Oh.
Yeah. It's not the water part of the eye 100%. That is aqueous humor, which is in the front of the eye. So the front has aqueous humor, and the back has the vitreous humor. And the vitreous is a little bit thicker.
What is the purpose of the retina? What is the retina, and what is the purpose of the retina?
So when the light comes through the pupil, it focuses on the retina, and the retina, I describe it like, you know, the older cameras had film in it, and it had a lens, and for you to get a good picture with your old camera, you really needed to have good film. Imagine if you remove the film or something, then you cannot get a good picture. The retina is the same thing. It receives all the information from outside, and it forms a picture very similar to what is on the outside on the retina. And that stimulates the nerves, and it goes down the optic nerve to the brain. So the retina is really nervous tissue that transmits all the information to the brain.
From my little primary school and secondary school education, I was told that when the images that the eye captures falls short of the retina, then you're nearsighted, and if it falls beyond this, you're farsighted. Am I correct in in what I read?
Yes, yes. So yes, correct. So in myopia or short-sightedness, the eye is actually a little bit. Most myopia is what we call axial myopia, where the eye is a little bigger than this size. So if it's a little bigger, all the rays falling in front, not really reaching here. So you have a defocus. Everything is a little bit out of focus. Yeah. And what we do is we put a little lens in the front, which is your glasses, and that will refocus all the light now to fall on the larger eye or the retina.
The last eye test I did, the doctors told me, the optometrist said that my eyes are getting better. That the prescription has become weaker from where it was, meaning that she said as I got older, my myopia seems to be it tends to get better. Is it, in your experience, in terms of, for those who are listening out there, is it that the eye can adjust itself, meaning that there's some sort of inward healing that takes place from time to time in selected cases? So that's a general thing.
Yeah, what happens with time is the other part of the eye, which is the lens, continues to change or grow. So if the lens start to change, it starts to focus the light a little bit differently. So sometimes, and it happens a lot, as the lens starts to grow and expand a little bit in this spot, it focuses the light a little more onto the retina. And some people experience a second sight, what they call a second sight, which is improvement in their vision as the lens ages and changes with time. Eventually, though, that lens will form what we call a cataract, as if you could see here, this whitening of the lens is now causing a blocking of the light from coming through. So initially, you could actually get improvement in your vision as the lens change in size. If you happen to be myopic or short-sighted, it will improve your vision. But if you're actually normal-sighted, it will make you defocus. So some people find the vision getting blurry, and then some people find it getting better, which is they need a lighter prescription. It's not really, it's getting better, it's just that the lens change, which is a natural change, is causing you to need a less strong prescription or a smaller prescription, you know? But not everybody. Depends on what they have. If they're hyperopic or not myopic, then they might experience the opposite.
All right. So perhaps we could try to marry that background information, that platform of information, to the diabetic's plight. What is it that diabetes and a diabetic condition, what is it in that situation cause impacts on one's eye? How does diabetes, the nexus between diabetes and a condition arising out of it that manifests itself through the eyes? How does that happen?
The most common problem we see with the diabetics, and that's why Leon Lazarus is so important, is the retina. And it's because diabetes, which is when the blood sugar is either high or it's high, and then it spikes. If it's high because it spikes a bit and then it comes down. So you have this labile blood sugar, or it's higher quite a bit, a long time, prolonged. when that happens, it affects the microvasculature in your entire body. And in the retina, if you look at the retinal vessels, which is again these little red vessels, this is a highly magnified view because look at the size of this. These blood vessels are what we call microvascular vessels. They're very, very tiny vessels. And they are affected or very sensitive to blood sugar fluctuation. And the capillaries, that's the microvasculature, the capillaries at that level, when the blood sugar is doing all sorts of things in a diabetic, they get damaged. The wall of the blood vessels get damaged. And the stuff that in the blood, which is not really the red blood cells, but the serum and all the other things, start leaking out into the retina. And when we look in the eye, we see usually some yellow exudates, which is cholesterol and lipids leaking out of these blood vessels in diabetics. We also see some hemorrhage, which is the red blood cells as the blood vessels burst or tear with the blood sugar fluctuation. So that's the main thing we see. And we see that in the early stages, and then we could start grading it, as Leanne was saying. And so we could actually tell you if your diabetes is under control or if your diabetes is really way out of control, because we could see the progression over time of the disease in your eye if we're doing the screening with the photography. And the photograph really gives us a time point status of your eye disease. So that's really amazing because let's say we took a photo in 2016 of a diabetic's eye, and we took a photo in 2024 of that diabetic eye, we could tell how good you have been controlling your blood sugar in the last eight years or so, dependent on the eyes. The other interesting thing we could do is, based on the amount of damage that we see into the microvasculature or the capillaries in the eye, we could tell if you should really get your kidney function tested or some other organ, because what happening in the eye is happening in your kidneys, is also going to be happening in your heart, is going to be happening in your brain. So we could, just looking at the eyes, have a good idea what is going on in your entire body and give you advice as to how to move forward with that. It's a very interesting question.
Wow. So, if I'm correct, from what Ms. Lazarus said, you're pre-diabetic, diabetic, you ought to screen each year. Is it, Ms. Lazarus, that when you screen, what may follow thereafter is a recommendation to see an ophthalmologist and to get deeper into what Dr. Bhola is stating?
Yeah, so we have a grading system, which I mentioned briefly. So what it does is allows us, when we assess, it allows us to put you in a category. So you categorize as no issues, if you have background, moderate, or severe. So what that allows us to do is we know now how we're going to follow up with your treatment. So if you have something like moderate or severe, we're going to send you straight to the ophthalmologist. If you have no conditions, no diabetic, condition in the eye, and you have low vision, what we can then do is clear the back of the eyes, and we can send you to the optometrist to address any vision issues. So and also what Dr. Bhola had mentioned is the changes in the back of the eyes. It gives us what we call biomarkers. So those biomarkers, now when we see background changes, is what will lead us to say, okay, we need to have further assessment done with your general practitioner. We need to have your kidneys checked, different things like that. So the eye really is the window. It allows us to see the first changes in your body from the diabetes and how it is affecting you. And it really does guide us to allow us to show you what is the best way and path to ensure that you have your health and also protect your vision.
What is your experience, Ms. Lazarus, generally when you examine a pre-diabetic's eye? Is it that the condition, there are certain standard things that generally present itself, or each patient tends to have a different sort of screen
So,
reading, if I put it that
so
way.
each patient is different. So it all depends on your control of your blood sugar. So I would, let's say I have someone who's newly diagnosed as a diabetic, but they have had a long period before that where they weren't taking care of themselves. The blood sugar was on control. And when I look, I may see major bleeding. I might have someone who's diabetic for 20 years. They're doing all the right things. They're eating well. They're checking on their eyes. They're making sure that they're doing everything they're supposed to do. And 20 years may go by and there's nothing wrong with the eyes. So it's very individual how diabetes affects the eyes. So it depends on the person. Once you're maintaining and you're doing everything you're supposed to do, and then there are also instances where someone may think they're doing everything right and then they have conditions in the eyes. And there are a lot of times also where people come and say, which you mentioned, Farid, that my eyes are good. I don't want to hear about it. I'm not going to check it when something is wrong, which is our culture, right? We tend to wait, which is why we treat a lot and we don't have preventative initiatives a lot in Trinidad. So a lot of times you will hear everything is fine with my eyes. I don't need to check it. But once you are diabetic or pre-diabetic, you have to make sure you're doing everything you're supposed to do in terms of your eye health and your overall health to make sure you remain healthy.
Dr. Bhola, I've been seeing optometrists for years, and I was told in order to see an ophthalmologist, I have to get a reference from an optometrist. Is it that the procedure is that one cannot access an ophthalmologist without a reference from your optometrist, or can the listening public out there who listening to what you're saying and internalizing it, could they go directly to an ophthalmologist? So you need to get a reference, be screened, and then if it is you qualify, you get to the ophthalmologist.
Usually, the general practitioner, the person who diagnosed the person as being diabetic, they would refer that patient to the ophthalmologist, and that's a good way for us to see the patient, because if we see somebody who is diabetic without that communication and contact, it means when we pick something up, we can't write back to the we don't have anybody to write back and say, hey, this patient, I saw this patient today, and I think we need to do more here, because obviously the diabetes looks out of control or something, I see things in the eye. So it's always good we get referred by the general practitioner. They should really be the gatekeepers, because we need them to know what is happening in the eye, because it's a systemic disease. It's not an eye-only problem here we're dealing with. And we need them to be working with us as a team for the patient's best interest. So that would be the ideal scenario. Sometimes we would see patients without the general practitioner referring. And actually, a lot of times, they come in many ways to us. The majority of patients just call the eye clinic and they get an appointment to see us. So we don't have a system, and I don't think any doctor in Trinidad, any eye doctor, has a referral only practice. We see people based on they call in the practice, and the receptionist or the person taking the call would book an appointment to see the ophthalmologist. So I don't think we need that referral to see any patient, that is diabetic, non-diabetic. You call the eye clinic, we're going to see you. But the best system is still to have a general practitioner as the center person looking after your health, because they will know your history, whether you're diabetic, whether you're hypertensive. They will make sure you start getting the right advice. If you're smoking, they will talk to you about that and try and work with you to get that under control, for you to quit smoking, things like that. Things that the ophthalmologist really doesn't do very well, because we concentrating on what we're seeing in the eyes and not really doing seeing you and monitoring your blood sugar every few months, checking what medication you're taking each one, and making sure we change and switch the medication to control your blood sugar, and then looking at working with you with your diet and making sure you see a dietitian and all of that. That's really the role of the general practitioner, who is usually very accessible to you because they either live, they're pretty close by, or you could get to them pretty easily.
So it would be safe to say that the general practitioner and the ophthalmologist, um, they have a relationship that works in tandem with each other.
Yes,
Once a reference is made, and then you do your work as an ophthalmologist, then you will be able
yes,
to advise the GP, the general practitioner, as to what you're seeing and how to approach the treatment of the patient.
yes, yes. And the thing is, if patients come to us without a referral, it's not a problem at all because we want you to come, you see, to get the eyes looked at. So if you happen to come to us, then we tell you, here, what, I'm going to give you a letter, I'm going to email it to you, I'm going to write it and hand it to you. But I want you, if you don't have a general doctor that's looking after you, to find somebody, because this is very important for your eye health. You know, we're seeing things in the eyes. We know you need to get on top of this blood sugar. You cannot be laxed again. You have to be more serious. We're seeing stuff now. So get yourself in better health. You know, and we give you advice, but we really need the general practitioner to work with you to get that advice into practice. You know, so that's how we do it.
So, for the ears of the listening public, I would imagine it's important that they have a relationship with a doctor in the context of a general practitioner that looks after them from year in, year out, where you can follow up, and they would be able to see what your medical progress or your medical history is like. So it's almost like a panoramic or multi-sectorial approach to treating with not just your eye issues, but your general problems.
Correct. You need really a team approach to get the patient, you know, the best treatment around. You need the general practitioner, you need the dietitians, you need the ophthalmologist, and we all have to be working together.
In my readings, I read where in Trinidad and Tobago there are 180,000 people with diabetes and another 60,000 to 80,000 with diabetes, but they're undiagnosed. Another reading I'm seeing from the International Diabetes Federation, Diabetes Atlas, the 9th edition, said that there are 428 million people with diabetes around the world and another 200 million undiagnosed. That sort of data it's a very, very serious, a tremendous statistic. Clearly, this problem is not in the minority; it's widespread. What is your view in terms of the need to have oneself tested, evaluated, checked, in terms of monitoring blood sugar levels and early ascertaining of whether one is pre-diabetic or diabetic? Do you see that as imperative? I mean, the statistics tend to suggest that it should be done.
Yes. I think for anybody who listening in, and we know that diabetes is now becoming, especially in Trinidad, you know, we average it at 14% of the adult population to have it or be at risk of getting it. I think that is an alarming statistic. You know, 200,000 people in Trinidad, we estimate, to have the condition. Some of them know, some of them don't know. Some of them who actually know, they don't want to accept it. I mean, that's the other problem we see sometimes. So, you know, this thing is out there. You need to get your blood sugar tested. You need to get tested for diabetes every 1 to 2 years. I think you know, once you're in an adult, and you should just get tested, because the testing is so simple to do. Most general practitioners would really be testing you for it once you go to visit them on a regular basis.
See, the thing with Trinidadians, and I guess it's Caribbean people generally, but in Trinidad in particular, people like to eat and they like to drink. And and the thing with eating is you you eat things that taste good, and what tastes good is food with sauces, mayonnaise, garlic sauce, mustard, ketchup, barbecue sauce, and then you tend to cleave to that business place that gives you a nice mix of all. You know, they make a bomb, a cocktail of all of that, and then you eat it 3-4 times a week. And then we talk to doctors like yourself who discouraging us from enjoying life and encouraging us to eat properly. And everything you recommend is bad tasting, but it's healthy.
Yeah, yeah. I know the challenge. Yeah.
Yeah, it's difficult. And then everywhere you go in Trinidad, every other corner, um, every food court around the savannah, in every other park when you're coming up the east-west corridor, if you're in south by the crossings, um, the temptation is always there. So regardless of what we hear from you, when we get off air and we get into our cars, you know, the devil presents himself and everything you said goes through the window, and you know, we say, well, we will deal with that problem tomorrow. Um, what is your view in terms of the the state approach to treating with or to in the education process? Because my view is a lot of these food courts. Let me use that food court by the Memorial Park in Port of Spain, right around the savannah. That is government sponsored. You go there, you set up your small business selling gyro and barbecue and everything of the sort. Um, there's no cost attached to that. Anybody can go there with their food badge, and it's a temptation presented by the state, and they have these things padded all over the country. Is it that you of the view that the state should get more involved in controlling these temptations? In other words, more rigorous intervention in order to ensure that the product that is on display or that which is out there being made available to the public, it's a healthier choice. Is it that the state is too lax in your view, or there should be greater more? The education is there, but the temptation far outweighs the education.
Yeah,
What is your
I
view
think
in terms of the state's approach?
I think that's a very political question, but I'll answer it. You know, I'll give my opinion. I think you're correct in a lot of ways there, Farid. One is, if we really try to get and eat healthy food, we actually have to make a big effort to try and find it. It's much more available to have the unhealthy options when you go out or when you trying to access food, and that makes it much more. Um, and there's two reasons why we go for it. You know, it's not only because it's available, but the cost factor is also an important factor. The cost of the unhealthy food a lot of the time is a bit lower in cost, so much more accessible to 80% of the population very easily, very quickly. And because of the accessibility and economics of it, people choose the unhealthy option 8 out of 10 times. Now, whether, you know, if the state starts to get involved in trying to make healthier options more available, I think that is okay, and allow people to have a little more of those options available to them. So incentives to encourage um, food suppliers to go in that direction. So if they provide incentives for that, I think that's a reasonable approach for the government or the state. But I wouldn't say that they should limit go the other way and try and limit the ones who sell in the unhealthy products, but really incentivize the healthy product vendors and try to get that more accessible in terms of financial accessibility and also availability on the east-west corridor. I think that's the way we should go with the food and the state.
Tell me something, Doc. Let me interject here a little bit, David McIntyre. Um, the sclera, am I saying it correct?
Yes,
The white
sclera,
part
yeah.
of the right, the white part of the eye. You know, sometimes you see people, and the white part of the eye, it's like reddish, like, or sometimes it has a sort of a yellowish color and thing. Is that an indication of pre or diabetic conditions?
No, no. Diabetes, as we were chatting a little bit earlier, David, and I think you probably heard a bit of the symptomatology.
Mhm.
One was the floaters, which could mean that you have the hemorrhage in the vitreous, which is the one we're trying to prevent all the time with all the screening. The
Yeah.
other thing that patients get is they get uh, fluctuation in their vision. It's okay, and then it gets a little blurry, and that's related to the blood sugar spiking and then normalizing as it goes up. The lens gets swollen because it gets some water within it. It's edema within the lens, and that causes blurry vision that fluctuates depending on the blood sugar. So that's the second thing they get. And then the third thing they get is they get a little reduced vision or a little patchy vision. So they're missing some things when they're trying to read or looking out at some signage or something. And that really is the sort of symptoms that we hear or we see in diabetics. The redness of the sclera, usually in Trinidad and really in the tropics, what we get right in the corner here is some little growths called pterygium. They're very common in Australia, in New Zealand, in the Caribbean, in these regions where we have a lot of sunlight. And these little growths produce a little bit of a yellow look in that area, in the nasal part of the eye. And they also get a little pink and red, depending on the Sahara dust and the sun, if you're out in the sun a lot. So that's the most common one we see, but it's not related to diabetes. It occurs in the general population. And sometimes people call it the smoker's eye, because
Yeah.
people who smoke also get a little bit of red eye. But that is what most likely is going on there, I think, David,
You see,
in the
I'm
person.
asking that question because I did some reading myself about the impacts of diabetes on the eyes of the human eyes, if I should put it like that. And it spoke of the damage to blood vessels, abnormal blood vessels. Um, I thought the damage of the vessels is probably what caused that reddish look on the sclera. And I would like you to explain how abnormal blood vessels or how blood vessels become abnormal because they're saying that there could be too much glucose outside the cells um, that they should be in that create problems of the diabetic retinopathy. So I needed to explain that more for the listener because I think I
Yeah,
understand that. But
I
I
know.
thought the reddish look was like symptoms or signs of the damaged blood vessels.
Yes. So the white of the eye, which is the sclera and stuff,
Yeah. Hmm.
is on the outside, and basically we have some coverings on the white called the conjunctiva, and the conjunctiva has the blood vessels that we see, and then deeper you would have some scleral blood vessels, but they are a little bit medium size. They're
Okay.
not the little fine ones that we find in the retina on the
Mhm.
inside. So
Yeah.
the diabetes affect the capillaries. That's the level. There are microvascular changes that
Hmm.
occur in the eye, and really it's the retinal vessels that are mainly the target or what is affected by the diabetes. Now, the second thing that you asked, a really interesting and great question, is how does the blood sugar cause damage to the blood vessels?
Yes.
The
Yeah.
capillaries. Now, the capillaries, is a single cell lining of the blood vessel. So as blood vessels go from being large to being really tiny, like capillaries, the lining of the blood vessel changes from a multi-cell, so a lot of protection, to a very limited amount of protection between the blood vessel and the other structures. So if you look here, this area here would have no blood vessels. So if anything leak out from this blood vessel into here, it will affect this functional tissue, and therefore it will affect your vision. So what happens with these little capillaries, because it's only one cell thick, if you get damage to that cell because the blood sugar is high, then it's easy to see how the stuff from the blood vessels will leak out because you have a damaged cell as a result of the blood sugar, and therefore leakage from that capillary. Now, what happens? How does, the question is now, how does high blood sugar damage the cell? Well, if you're in an environment of high blood sugar, and the blood sugar, because a lot of these cells have an insulin resistant receptor. This is the problem with diabetes. It cannot get into the cell. Well, the cell cannot get the energy and all the other things it needs to function and to work well. It dies, or it gets damaged as a result. It doesn't function well. And that's how diabetes affects the capillaries within the retina, and then results in edema in the retina, bleeding within the retina, and reduced vision.
Is it a domino effect with the impacts of this diabetes to the eye? You spoke of the edema. There's also the glaucoma, and there's also cataracts. How does it start, or is it like Fareed used the word a cocktail? Does it happen all at once, or is it like the domino effect? It starts here and it goes here and it ends up here and it affects this and then it affects that, and then you can be totally blind, or you can have serious eye issues. How does that process happen?
So that is why we screen using photography, retinal photography. So what Leanne's team they do is they have a camera which shoots from the front here and take pictures of this part of the eye, because here the disease affects first. So most of the early changes occurs in the retina, and that's why retinal photography has become the gold standard to look for a diabetic change within the eye. And once we start doing those, we could start seeing the early changes with diabetes. So that's a really good question, David. And that's why we focus on retinal photography as the best screening method for diabetic retinopathy. And I want to really congratulate Leanne and her ability to be so passionate and really get out there, because she realized that screening changes lives, and it does that in a mass way. She's realized that so much. She's formed a whole unit within Trinidad Eye Hospital called the Eye Screening Unit, the ESU. And that eye screening unit has now gone mobile. They now go out and screen people, and because they want to pick up this thing before it starts to cause blindness and problems. The cataract, sometimes people don't really get screened within the first 5 years of having diabetes. Either they didn't know they had the problem and time passed, or they delay for whatever reason. And then when we see them, we see in diabetic damage, but we also see in cataract, because cataract happens a little later on in the disease process. Now, how does cataract form in diabetes? Well, what happens is the blood sugar starts to fluctuate, and the lens start to change shape and size, and the cells within, which is the structures within the lens, these are fibers, lens fibers we call them. they have a certain anatomical shape. Um, they, with that change in the lens water content, they eventually become opaque. And that is what cataract is an opacification or a whitening of your naturally totally 100% clear lens. And that happens because of the change that happens in diabetes, where the blood, where the lens starts to get filled with a little bit of water and then normal and filled and get normal. And that causes the formation of the cataract. But that happens later on in the process.
Okay.
Let me just talk a little bit about the third thing you mentioned, David, because so much you mentioned in that little question is the glaucoma. You know,
Yes.
glaucoma, when it's caused by diabetes, because the majority of glaucoma we see is not related to diabetes. It happens because people's drainage system in their eye is just aging, and that natural aging process within the drainage system could lead to the pressure going up in the eye because you're just not draining it fast enough. You're producing it at the same amount you were producing it when you were young, and as the drainage system, like any sink, gets clogged up, the pressure goes up, and you end up getting glaucoma. And that we call primary open angle glaucoma. That is the normal type of glaucoma we see in the population. And when we screen for diabetes, we pick up a lot of glaucoma that is not related to the diabetes, but is open angle glaucoma. It just is prevalent within the population. And therefore, we're not only screening for diabetes, we're actually screening for every disease. Now, Leanne changed the name of her program from the diabetic eye screening program to the comprehensive eye screening program because she realized that she was picking up people with cataract, people with glaucoma, and people with diabetic retinopathy. So she decided, here, well, this is not a diabetic eye screening anymore. This is comprehensive eye screening. Now we have a comprehensive eye screening unit. And when they go out, they don't only screen diabetics, they screen anybody because this population we have at risk of glaucoma and they are at risk of diabetes, and both diseases are treatable. We want to really prevent blindness from anything, not just diabetes. I know we're on forum talking about diabetic retinopathy and diabetes. But let me just lastly mention diabetes and glaucoma. The type of glaucoma that occurs in diabetics, it occurs very late on in the disease process. And that is when the blood vessels that cause the diabetic retinopathy causing so much problems that they start to form new weak blood vessels that grows into the drainage system in the front of the eye, which is in the front here. The drainage system is in the angle here. And the blood vessels grow into that area because the diabetes is really bad. And that clogs up the drainage system. And that is very difficult to treat. We usually, when we see that, we start to use injections in the eye to shut it down because we had to shut it down real fast. And then we usually do a surgery to put an alternative drainage system within the eye to be able for the eye to be able to function normally. So it is a much more difficult problem when the glaucoma occurs because of diabetes. Because of diabetes.
Okay, thank you so very much. Farid, before you continue, I want to know what is the relation of well, I call diabetes the breathing ground, the spawning ground of all kind of diseases. Okay, so tell me, being as it is, when diabetes affect the eyes, um, what are the chances of you well, especially people who don't go for checkups and things, what are the chances of you um knowing that something is going to happen or something is happening beside the blurriness or the floating stuff? You might see little things like little specks going across your eyes and things, and I understand that, how can one, you know that, I need to check my eyes? I mean, outside of the blurriness, is there some sort of a feeling, a sensation? Are there headaches? And what is the relation between the diabetes? You've been talking about the buildup of pressures and stuff. Is hypertension any part of that too? Are they
Yeah.
tied in together?
Yes, yes, they tie together. So a lot of diabetics, especially in the early stages, would not have any symptoms. So
Okay.
that's really important to mention. It could be asymptomatic until pretty late on in the disease, and that's why screening every year is really really important. So I would say anybody who is diabetic listening to the program and really haven't had their eyes looked at, and even if you have no symptoms, you really need to get the eye screen. If you haven't seen somebody within a year, then contact us. Another note, our screening program is free.
Hmm.
So it is, there's no excuse for you
Right.
not to come in and get your photograph.
Yeah.
You know, you call us, you come in, you get your photograph, that's it. Next year, once we have you on our system, we're going to call you
Hmm.
and remind you to come for your screening. So that's a really important thing to let people know.
Yeah.
Get onto the program, get onto our eye screening program, and let us take care of your eyesight. There's no referral needed. The, the thing is, if you start to experience symptoms, which is the floaters in the eyes, the blurry vision, um, and other things, let's say you're getting headaches, it could be that your eye pressure up, you have the, you might have glaucoma, anything that affecting your eyes. I think it's your eyesight. It's the most important sense for you to look after. You could live without something else, but living without your eyesight is going to be very challenging
Yeah.
for you, and really would affect your quality of living. So get the eyes checked, because you may not know that you have things going on in the eyes.
Okay.
You're diabetic.
Yeah. There's a question here on the comments board. I don't know if we
Yeah.
are at that point of the program, but this person is asking. D. Redman is asking, what surgery a person does to have 20/20 vision. I think it's a political kind of question, but if I'm to put it into a nowadays answer, like in this modern times, because there are so much things happening now. Like you said, there's the Sahara dust. There's even something that I read about being exposed to um to different rays, these kind of ultraviolet rays and all of that. I don't know if that falls into Leanne's portfolio. Sometimes it's being advised that you wear darkers, as we call them, or dark shades. What kind of protection that helps for people with or
It,
without diabetes?
kind of still in my area there. So those two questions interesting. The 2020 question, and then
Hmm.
the one about sunlight, the harmful effect of UV light on the eyes. As we were talking earlier, we mentioned a condition called a pterygium, or a growth on
Yeah.
the inner part, or the nasal part of the white of the eye, which
Hmm.
could get red with the Sahara dust and stuff. And really, if you wear, we think the shades or the darkers, even the ones that you get in the pharmacy that you could get at a very reasonable cost, almost all of them prevent the UV from getting to the eyes, and they usually have a little tag on them say UVB protection,
Yeah.
and that's really what you want. And so get shades is a really important thing. Our sunlight that we have now, and the ozone being
Yes.
so thin, it's very important. You're going out there, and if you're going to be out there for any prolonged periods, like you're going to the beach, or you're working, especially people who work outdoor, you,
Yeah.
you really have to protect your eyes from the sun, using the sunscreen, or sorry, the sunshades.
Yeah.
Make sure you have that on. So definitely that. The other issue with the 2020 vision is a good one, because nowadays, obviously, we have procedures which could be done, which could get you either glasses free, so you have 2020 vision without glasses, and it really depends on the age group. The younger persons would have different options,
Hmm.
especially if they're myopic. And then as you get older, not nowadays we have better and better lenses that we could put in the eyes if you happen to have cataract. Now we do refractive cataract surgery and make people uh, really they don't really need glasses. The majority of people who use these new and amazing premium lenses in. So you come in, you see somebody at the Trinidad Eye Hospital, and then we tell you your options,
Yeah.
for 2020 vision.
Okay. Thank you. Farid?
Farid, you're muted.
Yes.
Dr. Bhola, I was reading where, in keeping what David asked just now, in terms of you're diabetic, blood pressure is important because I would imagine with increased blood pressure, that is it's a double whammy. You're diabetic, you have blood pressure issues. Blood pressure, diabetes, cholesterol. Usually these go hand in hand. It's a tandem of three. It's one can only imagine that the combination, the cocktail of diabetes with high blood pressure and cholesterol could only make things worse. What in your could you walk us through that threesome there in terms of what in that cocktail makes your condition even worse and makes you more at risk, if it puts you more at risk?
Yeah, we think just like diabetes affects the capillaries, having high blood pressure doubles your risk of developing diabetic retinopathy. So it is a significant risk factor for the development of diabetic retinopathy, having uncontrolled blood pressure if you're diabetic, and having uncontrolled blood sugar and having uncontrolled blood pressure really means you're at high risk of developing diabetic retinopathy and other eye-related conditions that could affect your vision, which is it could affect the optic nerve, lead to swelling of the optic nerve. It could affect the eyes in other ways to make you higher risk of developing glaucoma. So blood pressure is very important in diabetics to have under control. So when the GP sees you, he would be very keen to get your blood pressure as low and as safe as possible in terms of getting it as low as possible. There's a recommendation on that in diabetics, how low to go, but with blood pressure. The cholesterol may be less of a risk factor in the development of diabetic retinopathy, in our opinion. So we don't really put as much emphasis on controlling your cholesterol as we put on blood sugar, on blood pressure when you're diabetic for the eyes. The other third, I would say the big risk factor in that development of diabetic eye disease or diabetic retinopathy, which is the most common one, is smoking. So smoking, blood pressure, and diabetes, those are the big three that really causes these are the main drivers for the development of the diabetic retinopathy.
Wow. I would imagine. What about secondary smoke? For a non-smoker like myself, I could say, well, okay, I don't have to worry about smoking. But for us out there, who we are exposed to secondary smoke, is the intake of secondary smoke a concern? Meaning that we should try to avoid areas that you're more exposed to smokers and the effects of secondary smoke, or secondary smoke is not a concern. It shouldn't be much of a
I don't think it's much of a problem, because if if you're a smoker, it means you're really inhaling it directly into the lungs, the deeper tissues of the lungs, and that's how it affects you. And a lot of them smoke 10 or but quite a lot a day, because they have the habit of doing it. But secondary smoke, you might be exposed to it once ever so often, and also you're not really inhaling it directly into the lungs, unless you think you're being exposed very regularly to the secondary smoke, and like you might be working in an environment where everybody just smoking in an enclosed room, well, then you have a problem. It's like you are a smoker, you know, but that's not a common situation. For most of us, it's we go into an area, you know, into restaurants. Luckily, there's rules now. The smokers go outside the restaurant and outside the public spaces. But I don't think we have that as a concern.
There's a growing trend, I guess it's a worldwide trend, and everything that happens out there eventually filters to us in the Caribbean and Trinidad. What about vaping? Is vaping a concern? Does vaping as an alternative to smoking, and everybody seems to be vaping now, do you see a relationship between vaping and smoking, or vaping similar to smoking, that can result in an issue?
I haven't seen anything with vaping and diabetic retinopathy. Let me ask Leanne, maybe she might have seen some data on that. But from my readings and knowledge, it's not linked like how smoking is linked to diabetic retinopathy. Lee, and anything with that you picked up?
No, not that I picked up. No.
All right.
I wouldn't go and say vape away, you know, vape away, you know, it's better. But I really haven't seen a link between diabetic retinopathy and vaping. You know, even in my practice.
It's a relatively new thing too, so we wouldn't have that kind of information. Maybe in the next 5 to 10 years, they might do a study on it, but I don't think.
Maybe we can say vape away and then we'll figure it out.
But you know,
sorry, David, I didn't mean to give bad advice, you know.
But it gets even worse now. Here was my question. In 2019, we decriminalized the use of marijuana in small proportions. So you can have up to 30 grams of marijuana in your possession for personal use. What is your view in terms of marijuana smokers and how that could have an impact? Is there really any correlation, or do you foresee the decriminalizing of small amounts of marijuana and an increased use of it as a result having an impact in terms of it doesn't flow well with someone who's diabetic and so on? Does it add value? Does it not add value? Or the jury still out on it in another 10 years?
Yeah, I think it's a very good question because there was some reports that smoking marijuana, well, not smoking, but marijuana was linked to a treatment option for glaucoma patients because it did improve or lower the eye pressures in patients who had glaucoma, and therefore reduce their risk of developing further damage to their optic nerve. So there was a lot of thinking along that lines with marijuana, and they actually still working on trying to produce marijuana eye drops so that, you know, we could get the medicinal benefits of marijuana or cannabis, right? Sorry, I should really say cannabis. So that is being looked at still. What is the medicinal benefit of cannabis to the eye? And the jury is still out as to if it is a useful thing and if it is not useful, or if we could somehow get onto the part of the cannabis that is very useful for the eyes and make it into some sort of drop or something that is easy to take in. And therefore you could start using it for eye conditions. So we haven't really been able to get to that point yet with cannabis and the eyes. From our knowledge and experience though, smoking nicotine is really where the issue is. It is cigarette smoking that causes major issues in the eye, in diabetics, and marijuana, we're still not sure that really has any ill effects on the eyes in diabetics, and we don't think that we could say to somebody who is using that you know it's beneficial or there's a negative connotation to it. So we can't really advise you if you're using it.
Doc, you mentioned eye drops. I know we are getting into treatments and stuff now. Um, there are some people who are really afraid to go see doctors and things. Some people think, well, they can use whatever over the counter. What about the use of these eye drops? A lot of people use them, especially where diabetics are concerned. Is it advisable?
Yeah, most of the eye drops that you'll get from the pharmacy, you know, is pretty much the over-the-counter medication, and the over-the-counter eye drops fall into mainly um, lubricating eye drops, and those lubricating eye drops are very safe generally to use. The ones that we worry about is anything with a steroid in it. So you always have to be careful if you're given an eye drop. Just read what is on the
The label.
on contents, and if you see like prednisolone or dexamethasone, anything with a zone, SONE, or ONE at the end, is usually indicating that you're going to be taking a steroid. And really, you should probably ask the pharmacist for something which doesn't have a steroid in it, because sometimes they might want to give you something a little stronger, and really you should just go for what is safe. And what is safe is the lubricated eye drops. And luckily, the majority of the pharmacists out there, that is what they give you. They give you what is called the over-the-counter drops, and those are the lubricated eye drops. They sometimes give you an anti-allergy drop, which is an antihistamine. That's also very safe. So just look out for the ONs, the ONEs, and just read the bottle. I know sometimes it's pretty small, so you might need to put on your glasses, but have a look at it. A good way to do it too, sometimes you take your phone out, take a photo of the contents, and just blow it up a little bit, and you're able to see what is on the drop. Yeah.
Fareed?
So many doctors recommend exercise, and particularly if it is you in high stress jobs and you work long hours and you have to focus. Sometimes at the end of the day, if I talk from a personal point of view, I get this pain from the back of my neck coming through the crown of my head. I feel it all in my eyes. When I go to swim, after I swim for about 45 minutes, I'm a completely new person. So I am one of those persons who believe that exercise helps a lot. It takes just pressure off my mind, and I feel differently about myself. What is your position in terms of exercise? And does it play a role in controlling blood pressure? Does it play a role in perhaps nourishing the eyes in some way? Is there any direct or indirect relationship? Or is exercise just a figment of our imagination?
No, I think, if we put smoking, hypertension, and control of blood sugar in a diabetic as the top three, I really think a healthy lifestyle has to be talked about as very, very important. Physical, as you mentioned, you must always try and be in top physical health, the best that you could be, because not only does it help your cardiovascular system to function optimally, it would be helping to reduce weight, which is very important in diabetics, because weight gain results in worsening uncontrolled blood sugar and hypertension and all the other things. So regular exercise is a key thing in a diabetic population. And it's one of the things that I know Leanne and her team would be advising all the people they see who are diabetic to make sure they develop this healthy lifestyle and get as much physical exercise as you can get in the day. Look at us here. We have to sit down and do this little academic exercise, which really limited our ability to do some exercise. But as you rightly said, as soon as you're done, you really want to change and introduce more non-sedentary activities. So if you could change more non-sedentary activities to more active activities, for instance, if we come off the call and then we go and sit in front of the TV for 2 hours, that's a non-sedentary activity. If we think about it hard enough and really we want to change that, we might say, "Here, let's go outside and take a walk and do some swimming." So if you start changing your lifestyle by looking at your non-sedentary activity and changing them into more sedentary, into more active activity, it will really enhance your health, especially if you're diabetic. It's vitally important to try and do that. And then even in your day, you could introduce what we call exercise snacks. Is a really nice term. I really like the term, where as you're doing your program, Fareed and David, you just get up and you do some little jumping jacks or something, try and keep the exercise going all day. I think those really useful. So it's not only what you do in the afternoon, but it's kind of what you could do all day to get your physical activity up. And the more you do physical activity, the stronger I think the body will get, the more unlikely you are to develop other the diabetic retinopathy and other things. But I think you're very, very right. We have to have a shift in how we exercise and move and do physical activity. It also promotes mental wellness. So one of the things you mentioned there is how you feel better, or the pain goes, and you're almost feeling like you're a new man. Basically,
Yeah.
your physical activity helps your mental activity, and all of a sudden your mind starts to breathe and think, much more airy, and then you're much more creative, and you go into that more creative space in your mind. And really, that's what you want. You want to do that. You want to use the physical to help your mental, and then that really drives you to become more aware of how you're living and controlling your diabetes. Because if now you have more passion to do it, then you might really go and see about your eyes the next day, because you're thinking, "Oh gosh, I remember now all the things I have to do." So I think it's critical to look after your health and do more physical, get more wellness into your life.
Leanne, in your job, in the work that you do in terms of uh, your eye screening unit, um, do you see a relationship between uh, and I don't want to I don't want to touch on people's corns outside there listening, but when you see people and they're obese, you're seeing big fat people, and you could already, before you begin to screen, well, I'm going to see problems here. Um, Body mass index. What is the relationship between body mass index and if there is, and persons who you are screening? Do you see that? Are you of the view that fatter people or obese persons, and I'm not saying that it would not manifest itself in people who appear to be healthy and strong. We associate slim built people with healthier people. I'm sure that that doesn't necessarily speak for itself, but in terms of how one physically uh, carry themselves, in terms of how they manage their bodies, is there a relationship between how one manages one's body and perhaps the screening results?
So, I think initially when you see someone who is more on the larger side, you would naturally start to think maybe I might see something here. I think it's more because you can be obese and then they can be larger, and then if their body is working properly and breaking down the sugar that they're consuming, then their eyes are okay. I think it's more individual. I don't think it's necessarily, well, obesity is linked with diabetes, right? So you would tend to see larger people who have uncontrolled sugar. You would tend to see that they have these issues with the eyes. But to say if I see an obese person walking, I automatically detect something. I can't say that's true. You tend to see it. I'm trying to be very political in my answer. You will see it, right? But there are also very small set people who, let's say, they were born with type 1 diabetes. They didn't manage it well. They look in good physical health, and then when we take pictures, they have a lot of issues. So I can't say there's a mold that fits in this instance, but of course, if you're not taking care of yourself, if you're larger or you're small built, you're gonna have some kind of issues.
Tell me something, Leanne. Where
Yes.
screening is concerned, we have people who do jobs that put a lot of pressure on the eyes. Let's
Right.
look at the diabetic people. There might be guys who are diabetic who are welders, and
Mm-hmm.
guys who are diabetic that do a lot of work in the whatever that um puts a lot of light, bright light strain on their eyes. How how do you see or how do you get a view of that? I mean, how do you see that in your screening system?
So more that one would be more or less any questions that we ask. So we tend to ask medical history in terms of their vision. We will ask them if you feel a lot of strain when you're reading.
Yeah.
Are things blurred? Do you get any headaches? Is there pain around the eyes? So those are more the questions that would lead us to go in that direction. Sometimes a lot of people complain about eye strain and they have good vision, and we usually send them to our optometrist for to see because there is this rule where we do 20 minutes and you're supposed to look away. You're not supposed to look at screens, but that's not, I mean, I look at images all day on a very bright screen, so I tend to do this for hours at a time.
Mhm.
So I think we would notice it a lot more because this is just how we operate in the world. Everything is on a screen. Our meetings are online. So I tend to see it a lot that people complain about that issue, and then of course I send them and direct them in the best way to get any kind of help or
Okay.
further assessment.
And welders in particular, they have what they call Akai and all of that.
Okay. Yes.
Yeah.
Okay. So and that's an instance where we have to be very careful, and I mean they have a lot of health and safety regulations that they need to follow, which doesn't necessarily happen. But
Mhm.
that's why those rules and those guidelines are very important in our working environment and in our health and safety um, area. So we need to make sure in that instance they have to follow the guidelines. And then if we see anything of concern, we have to send them to our specialist, which would be
So
Dr. Bhola and the other doctors.
Dr. Bhola is the specialist. Have you treated any patients who were diabetic and were welders who complained of that kind of issue of archives and all of that? How dangerous is
Well,
that for the person as a welder who is diabetic?
I don't think they are at increased risk of getting archive, um, because how the archive develops it is that the welding light
Mhm.
causes some inflammation on the cornea. So
Oh,
once you don't wear the safety glasses, you're at risk of getting it, damage to the cornea. Just to let everybody, if you get at it, don't get worried. It's self-limiting. The cornea replaces itself every 3 to 5 hours. Those cells in front, so it will be really bad for a little while, and then eventually it heals up. So if we happen to see you, we diagnose it by putting a little stain on the eye, and then we put you on some eye drops to prevent infection. I mean, that's the way we manage it. Um, the trouble with diabetics, if they do get it, is that their
mm,
cornea may not be um, able to regenerate as fast as a non-diabetic. So then you are a little bit increased risk of infection. So in a diabetic, I might keep them on the drops a little bit longer to
yeah.
protect them than a non-diabetic. So that's the only difference, David.
Right. I ask that because diabetics who get cuts on their feet and things, they end up in a lot of problems with infections and probably they lose the limb and all kind of things. So that's why I ask about welders who get archi and are diabetic.
Yes, I think they're more likely to need protection for a little bit longer because of the healing, the slow healing.
Okay, great. Thank you, Doc. Thank you so much.
This question we're going off topic a bit, but I have to ask. For those persons that are engaged in physical exercise and physical activity, such as contact sports, let me be very direct. Boxers or people who spar, and footballers who head a football all the time. What sort of risk do they run, or are they more at risk to develop problems with their eyes? How much pressure? The question is hinged to how much pressure can one put on one's contact with one's head through contact sport to avoid and stop short of experiencing difficulties with the eyes?
Yeah, we don't see a lot of issues with the boxers when they get punched and that sort of thing causing damage to the eyes. Because the eyes is really they're protected by the bones around very well, and there's a lot of padding in the orbit. The sports that we see eye injuries with is really what we call the finger injury, because the finger could come in and hit the globe and cause damage to the eye directly. So we see it in basketballers when they go up for the ball and they coming back down, their hands and they close to each other and the finger hit the eye, and then they come in with some serious eye injury. So that's one. We see it with squash balls. The squash ball is a little smaller than the cork ball, so that little ball now can really get in and hit the eye and cause some serious damage. We do have the cricketer, the cork ball that could cause damage, but that usually cause more fractures around the eye and doesn't really damage the globe itself. It's very rare for that to happen. Obviously, with the protection now that these cricketers have with the helmets and stuff, we hardly see much facial injuries from the ball. The footballers are similar to the basketballers in that when they take the corner kick and they go up to head the ball, they're coming down, all of them in the same area, they could get the finger injury, similar to the basketballers, to the eye. So, those are the main groups that we see with major eye injuries and sport, contact sport.
Wow.
Yeah, it's an interesting thing.
Yeah.
When we look at let's talk about the treatment. How expensive? And I'm not asking you to quote prices and figures to us. In Trinidad and Tobago, how accessible, and that might be tied to costing. How accessible is quality eye care and treatment? To see someone like yourself, do we have sufficiently qualified persons like yourself out there who are capable of having access to persons, or the public having access to persons like yourself? Or is it that we need more ophthalmologists, or we have an even spread here and more than sufficient qualified persons here? Because I'm asking that because we often hear that we have a shortage of nurses. Do we have a shortage of ophthalmologists and qualified persons like yourself to engage the public?
Yeah, let me kind of talk about that in a broad sense, because we've done a lot at the eye hospital to try and get everybody some care, eye care. So I want to ask Leanne about that because she's formed this eye screening unit. Let me get her to talk about that first, what she's doing there with the eye screening unit to try and get the masses screened, and then I'll talk a little bit about access to more specialized care in eyes. So Lee, I don't know if you could describe the eye screening unit for them and talk about that.
So the purpose of the eye screening unit is to kind of create pathways. So one of the major problems is, yeah, a lot of people rush to the ophthalmologist and then they will have a lot of cases where there's nothing wrong. So that person is now taking up time away from someone who might need care immediately. So that's why we screen. So now, let's say on average, we refer about 50% of the screening population to our clinic. So if all 100% had gone to see Dr. Bhola or one of the other doctors, then that crowds the clinic. It reduces the speed in which they can be seen. So by us having a screening process where we divide patients into those not requiring care, we free up the doctor's time to be able to deal with cases they actually need to see. And that also speeds up patient care. Then that's what is going to really save our patients' eyesight, because now they're going to be seen quickly. They're being seen because they actually need to be seen, and they're being placed in the kind of environment they need to. Because a lot of times people will have issues, but all they need is glasses. But they need someone to tell them you need to go to the optometrist versus crowding a eye specialist clinic. So that is the real purpose of our screening program, where we screen and then we know how to treat. So, and of course with screening, you're always going to keep coming back. So we're not going to miss something occurring. Once you follow up and you have that rescreen happening once a year and you come in when we call you, that will allow for us any change that happens, and with the pictures we have something to look back on. So we have comparison. It's not just notes in a file. We can physically look at the images and say, oh, maybe you have one more blood spot, which could make a big difference, because then now we know you're not doing what you're supposed to do. And we can talk to you again, and you can go to your general practitioner. You might have to change your medication, but it allows us to kind of create that rupture with our patients, where we can talk to them and then we could also guide them. So we free up the doctors to do what is necessary for patients who actually need care.
And the interesting thing too, Farid and David, is that Leon, when they do the photographs of the patient's eye, they could show them on the screen, you know,
Yeah.
what's happening. So then patients start to notice, oh, that is what happening in my eye. I can
Yeah.
see it, you know,
Yeah.
and that really helps them now to get motivated to make the changes in their life that is needed. And the good thing about Leon's team is they spend a lot of time with the patients, giving them advice, and then when they see them again, they give them they do the same thing again. So patients now starting to get the information over and over, and you know, repetition is the key to for change. Leon's team, they this year they will screen somewhere between 10,000 to 15,000 patients.
Wow.
So, you know, if I had to see 10 to 15,000 patients, that would be a real problem. Yeah, you know. So I think the team has work to do. You know, we can't look at this thing as everybody in Trinidad call their ophthalmologist and go and see them. You know, that is not going to work out, because you won't have enough ophthalmologists to be able to take care of the entire population of Trinidad and Tobago. Plus, you're going to get free screening. So, you know, you can't, and just because it's free doesn't mean that it is lesser than going to see the ophthalmologist. It is not. It is actually better, because they're going to take photographs of the inside of your eye and they're going to track that over time. The ophthalmologist will see you, or the optometrist would see you, but we don't track you like they do over time, and know every little change that goes on there. We will take a look at the eyes and say, okay, the eyes look like you don't have any major disease, yes, but and then see you back in a year. And in that year, it's another first time point that we're looking at. And we don't remember what was in the past done there. We could take photographs, that's true, but we don't do it like how they do it. They follow a very rigid assessment schedule that is quality assured. You're using repeated methods to ensure that they do it following the guidelines from the UK. So it would be wonderful, if we could show you that process. It's a great and amazing process in how they do the diabetic screening. In terms of availability, our clinic structure at the eye hospital is set up in such a way that we have the ability to see large volumes of patients in our clinics, and we run clinics every day in both locations, in both the Masca, the south location, and then at the Tunapuna location. We have about 6 to 8 doctors. Normally on site, we'll have 2 to 3 doctors per clinic session there, and we have a lot of support for the clinic. So our team is usually about 20 to 30 people in the clinic at the same time, doing screening at the same time that's going on. They do scans in the eye, they check vision, and they see the patients with the doctors. So we have a lot of technical support within the clinic to allow the doctors really to only do the part of the examination, which is absolutely their area, which is see things when things looking like there is a problem, and then treating the patient. But a lot of the other things are done by the technicians that we have, well-trained technicians within the eye clinic. So I don't think we have any issues with overload within the clinical setting for the eye doctors.
No, I'm glad you said that, because I wanted to ask you if the eye clinic. Well, I come from all the way from Ludbury to Port of Spain, every day. So I saw the eye clinic there at Masca, and I was wondering if this is the eye hospital you're talking about. So I'm happy that you said that, so I can be more precise in my location. I would say it's on the South Trunk Road in Laramie, in the vicinity of the Gulf City. I think, so because I see it all the time, and I always ask myself, an eye clinic, an eye hospital, because Masca, that area, it's a multifaceted business area, We have the eye hospital there, we have other business entities there. So you're talking there now, and I'm saying, okay, before the program is out, I'm going to ask you where the eye clinics are located. So I can say that exactly where it is, but in Tunapuna, exactly where is it in Tunapuna?
So when you're coming down the highway and you get to the lighthouse, by that traffic light there, we're in that compound where the lighthouse is.
Oh, okay.
They used to be the FedEx there as well, and they left, and we built an eye clinic there.
Okay.
That's in Page.
That's in Page. That's Page.
So not by Page, where you have all those lighting fixtures being, and it's on 24/7. Yeah, I know it's Page. So it's right opposite Radio Jagrati and that the school.
Yes.
Yes.
Yeah. And how can people connect with the eye hospital if they're listening to the program, social media and stuff?
Let me let Leanne answer. She might have all those numbers.
Yes, Leanne, that's yours.
So the website is Trinidad Eye Hospital.
Eye hospital.
Yes, and then also our number is 235-4TEH or 235-4834.
Okay, I want you to repeat those numbers a little slower.
Sure, 235-4TEH or 235-4834.
Thank you so much.
No problem.
I know there are some people who are listening. There are some people who are not really savvy. So the telephone number will work absolutely well for them, Farid?
Dr. Bhola, what are the regional comparisons? Let us say, in your experience, I would imagine you would liaise with persons similarly qualified like yourself of the Caribbean. Let's say, I'm just calling randomly, Barbados, Guyana, Jamaica, maybe St. Lucia, Dominica, the usual trends. Is the problems, or are the problems that we see in with our own people here in Trinidad, is it similar of the Caribbean? Are we, when we compare, quite within the ratio uh, in terms of problems, or is it more pronounced in Trinidad than it is in other places? Or does it compare uh, when we look at it regionally in terms of the Caribbean? The problems associated with retinopathy and so on.
Yeah. With the diabetes, I see it all over the Caribbean. We actually travel quite a lot to do eye surgeries um, outside of Trinidad. We go to Antigua, Dominica, St. Lucia. Um, so we go out 10 to 12 times a year to do surgeries. When we go out to do surgeries, we also do clinic with the doctors there, and we get to see the cases or the type of eye problems that they're encountering in the islands. And it's very, very similar to what we have in Trinidad. The diabetic retinopathy is pretty advanced because of the lack of screening. You know, Farid and David, this lack of screening, at some point we have to see how we could address it at a national level. Because you have companies like the Trinidad Eye Hospital that really put in a lot out to do this screening. But really, we need to screen the majority of the diabetic population in a national program to really have good impact. And the government has tried to develop national screening programs, but not so successfully. And that is in all the islands too. So when I go to the islands, I really usually meet with the minister and other people like that to try and influence them in doing screening for their diabetics and developing screening programs, because we know that it's a game changer for the country that is being treated. So it is very important, I think, for us to make the decision makers aware that they should look towards doing diabetic eye screening for at a national level. It reduces your incidence of diabetic retinopathy from what we see in diabetic retinopathy being 20-30% in the diabetic population that we screen. It reduces it to below 5% if we get the screening going and done well. So it's really a key thing to change in the amount of eye damage and disease that occurs in your diabetic population. And really, it's a no-brainer for our government, because your diabetic population, in the majority of cases, is your working population. That's when they develop all their diabetic eye disease. So if your working population not seeing and leading the country, you really have a problem, So you really need to be addressing this diabetic eye disease to really have a good working population that really will take you forward and improve your country. So it really is something that needs to be told to the decision makers, that they need to focus on that. Preventative medicine is the key. In the islands, though, to give some perspective, the amount of diabetic retinopathy is a little bit less than we see in Trinidad, which could also be said the other way, which is the diabetic retinopathy problem in Trinidad is more. That is, and we think that is because of the larger Indo-Caribbean group that is here. And we see the diabetes a little more in that population in terms of percentage. So it affects the Indo-Caribbean population more. So the amount of diabetics that we see in Trinidad and in Guyana is higher than in the islands. When we go to the islands, we see a lot more glaucoma and cataract, whereas in Trinidad, we see a lot more diabetic retinopathy.
Tell me something, Doc. Should someone be bummy or scary when they hear about eye surgery?
Well, the majority of eye surgery is cataract surgery, right? that we do. And cataract surgery is really the most amazing surgery ever invented, because you're taking a person who's not seen and you're giving them almost 20/20 vision with surgery. So
Wow.
no, if you're going to have cataract surgery, I really would, in my mind, tell you do not be alarmed at all. It's a 10 to 20 minute procedure most of the times if everything going okay. And usually you come out, pretty much like you went to the dentist. It feels a little odd, and
Yeah.
then it will get
Yeah.
better really fast.
You
So-
know,
so don't
I
be-
want to make the comparison with the dentist.
Yeah, I think it's a great comparison because you get the anesthetic. It's very similar. You feel that swollen kind of
Yeah.
eye instead of jaw.
Joe. Yeah.
And then that eye swollen feeling or numb feeling would eventually pass off in about 2 to 4 hours. So and then your vision comes back. We usually pat the eye up for about 6 hours so that you're not worried about anything there, and
Good,
then we
great.
tell you to take it off after 6 hours, and then your vision is coming back. So
Leanne, when I see you at the masker outfit there.
I go everywhere. So we have, like Dr. Bhola would have mentioned in the beginning, most of our screening is outreach. So we go into the community and we trying to make it as easy as possible for citizens to have the opportunity to have their eyes checked. So we usually about 5 times a week we go out into the community and we do the free screenings, and then we have them come in to see the optometrist or the ophthalmologist if needed. And then also we have our in-clinic screenings as well. So for MASCA, that would be on a Wednesday,
Wednesday.
and Page would be every Monday. So we have someone stationed there who would see. Of course, you call in and book an appointment because we have to give you guidelines to do the screening, because it is a dilated exam. So we want to make sure we explain that to you. And once you call, you book. We have the screening every Wednesday in Masca, Mondays in Page.
Okay. Thank you so much. You advertise when you go into these communities, right?
Yes, we advertise very heavily. We have a really good marketing team behind us. So we mostly advertise on our Facebook page. There are links to sign up. So you will see where we go to every month. So like this month we're in Davie, Labre, Chagonas, we're everywhere. Mayaro, Rio Claro. So we tend to go all over. I'm never in the same place every day, which can be fun or exhausting. You can choose. But yeah, we want to make this service available. We want to limit your excuses to not make your health a priority.
Yeah.
And you can always check our website and our Facebook page for where we are next.
Okay. Thank you so very much. Maureen?
We want to thank both of you all, Dr. Bhola and Ms. Lazarus, for making
Yes.
yourself available today. You've explained yourself so well and so warm and so friendly. You know, the general population's perception of doctors is you all are very stiff.
Yeah.
And, you're not really open with your information. It's almost as they keep you in the dark and they
Yes.
just tell you whatever you ask, and you don't get a comprehensive explanation. So you all have done a pretty good job, a great job today in giving us that holistic approach to things. And sometimes the information helps. So I have to thank you for that and for making yourself available to us. Thank you so much. Dr. Bhola and Ms. Lazarus, hopefully we can invite you all again. And once it meets your timing, we can do another show, perhaps dealing with the eyes in another way.
Yeah.
Yeah.
I mean, we have so much we could talk about. We now start to touch on things. So anytime you let us know.
Okay. It's
So
been a
thanks again.
fantastic show.
Enjoy your
Very
afternoon
informative.
and best wishes again. Thank you and have a safe journey home. David, same to you.
Okay. Thank you, guys. It's been really, really informative and very, very helpful, I'm sure, to a lot of the people who were listening. Thank you so very much.
You're
Thank you.
welcome.
Bye.
Enjoy evening. Take care and blessings to the public. Thank you.
That's it for today's edition of Heart Talk with Fareed Ali. We touched on the effects of diabetes on the eyes. Fareed will be back next Wednesday with another interesting program on Heart Talk Power 102 Digital.